Now let's talk about the laboratory evaluation of a patient with type 2 diabetes. You'll want to check a CBC, fasting lipids and CMP, TSH, 25-hydroxy vitamin D, spot urine microalbumin creatinine ratio, and hemoglobin A1C for your patients with type 2 diabetes. A CBC will help you identify anemia, which, if present, can make an A1C unreliable. A fasting CMP helps you understand fasting glucose, but more importantly, gives you insight into kidney and liver function. Patients with diabetes are at higher risk of kidney dysfunction, and this may take some of the medications off the table for you as therapeutic options. Many patients with type 2 diabetes also have fatty liver. A CMP may give you insight into that and whether you need further workup for their liver. 25-hydroxy vitamin D is important to know about their bone health, and many conditions are being found to be associated with low vitamin D. This is an easy thing to identify and replace if needed. TSH helps you understand whether there may be other causes of symptoms of diabetes or high cholesterol. A fasting lipid panel is necessary. Triglycerides may need to be intervened on, but oftentimes they do reduce with lowering blood sugar. HDL and LDL help you assess your cardiovascular risk in your patient with type 2 diabetes. LDL goal in patients with type 2 diabetes should be less than 100, but if they have cardiovascular disease, the goal should be less than 70. We also should check a C-peptide on initial visit. Sometimes type 2 and type 1 diabetes are not so easy to differentiate, since many patients with type 1 also often have obesity. We have to check a C-peptide to ensure they have pancreatic reserve. Antibodies for type 1 diabetes should not be routinely checked. GAD65 antibodies that are present in latent autoimmune diabetes of the adult can also be present in the general population and be inactive antibodies. Many patients with type 2 diabetes actually have positive GAD65 antibodies. Checking these routinely can be confusing for both physicians and patients, so we don't recommend routinely screening with GAD65 antibodies. Other antibodies for type 1 diabetes, like islet cell antibodies and insulin antibodies, also should not be routinely screened. A1C should be checked every 3 months, and B12 should be checked periodically in patients treated with metformin. To review labs needed for diabetes. On initial visit, we need CBC, fasting CMP, A1C, fasting lipid panel, 25-hydroxy vitamin D, TSH, spot urine microalbumin creatinine ratio, and C-peptide. A1C should be checked every 3 months. Spot urine microalbumin creatinine ratio should be screened yearly. B12 should be checked periodically for patients on metformin, and do not routinely check antibodies because they can lead to confusion for both providers and patients.